Hello again, and welcome back. This is Michael Berry, a general internist at Massachusetts General Hospital in Boston, and we're going to continue our nurse training presentations with a examination of the Treat to Avoid Symptoms nursing protocol in the TRUST trial. And more details are available in the Treat to Avoid Symptoms nurse training manual. So the way TRUST works is there's an evaluation of the patient for eligibility and seeing if they're willing to participate. Their consent is obtained all before the nurse gets involved. The nurse is notified when a participant who has agreed to participate is randomized to the Treat to Avoid Symptoms arm. A baseline visit is scheduled by the nurse or unblinded clinical research coordinator within 3 weeks of the screening visit. The nurse makes a pre-baseline visit call to the participant for an introduction and welcome and to discuss their preferred flare medication. Now in TRUST, colchicine is the preferred gout flare medication, but if the patient feels non-steroidal inflammatory drugs or steroids have worked particularly well for their flares in the past, those are all options for flare management. The nurse emphasizes the preferred flare medication will be given at the baseline visit with a backup supply of steroids if needed. Basically, we provide the participant with enough medications to treat 4 flares, and they can get more if they need to. By having this pre-baseline visit call, the nurse can assess and be ready for dispensing the right flare medications with the research pharmacy at that baseline visit. So the baseline visit is also attended by the clinical research coordinator, the CRC. The nursing focus of that visit is on participant education about gout in the trial. There's counseling about gout, why it happens, lifestyle and dietary issues, which are particularly important in this arm, effective abortive management of gout flares, including their choice of medication, and the importance of early initiation of treatment of a flare to head it off, if you will. The nurse and the participant work together to develop a personalized gout flare treatment plan, and the nurse explains how to get advice if the flare treatment plan is not effective, if their pain persists. They'll also say a word about reporting flares during regular calls from study personnel. This is not something the nurse has to do. A research assistant who's again blind to the patient's assignment of study arm will be reaching out to the patient about every 2 weeks, either through the electronic record portal or by telephone to assess if there's been a flare in the last 2 weeks. The study nurse will ensure that the appropriate gout flare medications are distributed to the subject at the end of the visit, and will appropriately document the visit in both the research database, the EDC, and the electronic health record, and will send a note to the participant's primary care clinician using a study template for the note after the visit. This is particularly important because in TRUST, what we're doing is we're asking the primary care clinician to delegate the gout management to us while the participant is in the trial, and they'll be more reassured that we're taking good care of their patients if we keep them informed about what's going on. Now, week 4 and 8 visits are scheduled phone calls from the nurse. The nursing focus for both calls covers, again, more counseling about gout, ask the participants if they have any questions about gout, their current treatment course, any problems with medication side effects. Also find out if there have been any flares since the last visit, the baseline visit. If so, how did the flare management work out? If the participant has no questions, reinforcing the appropriate flare management using their personalized flare management medications would be the next thing to cover. And then assessment of any treatment side effects and adverse events. Reinforce how the patient can call for help in managing a flare if their treatment plan doesn't seem to be working. And again, appropriately documenting the visit and keeping the primary care clinician informed. Now, visits at week 12 and 24 are scheduled face-to-face visits with the nurse and clinical research coordinator. The participant brings in their study medication. The nursing focus again covers counseling about gout, any questions the participant has, their current treatment course, how it's working, or any medication side effects. Have there been any flares since the last visit? And if so, how did the flare management work out? And perhaps some tips if there's another flare about things they could do to make that flare management more effective. If there are no questions, again, we reinforce the appropriate flare management using their personalized flare management medications. And again, those medications can change if the initial personalized treatment plan doesn't seem to be working. There's a studied blood draw associated with these two visits, and that can be either done at the visit when the person comes in, or if they prefer, they could come in earlier and get their laboratory work done. There's a formal assessment of treatment side effects and adverse effects. There's a pill count of the study medication. How much of the medication have they actually used since their last visit? Study drug distribution is done if needed. Perhaps the person hasn't had any flares, the best outcome, and doesn't need any more medications. But if they've used some of their flare management medications, they can be resupplied to have enough for 4 flares, not 3. And again, the flare management medications can be switched if needed. Again, the nurse appropriately documents the visit in the research database and the electronic record and sends a note to the primary care clinician. The week 36 visit is a scheduled face-to-face or virtual video visit with the nurse. It needs to be video for this because of the pill counts. The nursing focus covers participant counseling about gout, ask the participant if they have any questions about gout, their current treatment course, or any medication side effects. Have they had a flare? If so, how did management work out? And could it be done better the next time? And if there are no questions, we reinforce the appropriate flare management using their personalized flare management medications. There's no blood draw at this visit. There is an assessment of treatment side effects and adverse events. There's pill counts of study medications, which can be done virtually at a video visit. Study drug distribution, again, if needed. They should have enough for 4 flares, so we can resupply them if they've used some of their medicines since the last medication dispensing visit. And then again, appropriately document the visit and keep the primary care clinician informed. Now, as we move on, there are visits at 48 and 60 weeks. These are scheduled face-to-face visits with the nurse and clinical research coordinator. The participant brings in their medication. The nursing focus covers patient counseling about gout, again, asking if the participant has questions about gout, their current treatment or medication side effects. Have there been flares? If so, how did the flare management work out? Could it be done better the next time? If there are no questions, again, reinforcing appropriate flare management using their personalized flare management medications. There is a blood draw for the 48 and 60 week visits that can be done either at the visit, or if the patient prefers to visit a laboratory separately that's closer to home in some cases, that can be scheduled. There are pill counts of study medications at this visit and study drug distribution if the patient needs more medicines, enough for, and again, it's 4 flares. Again, that personalized management plan can be shifted if it doesn't seem to be working like this poor guy in the picture. We, again, appropriately document the visit and keep the patient's primary care clinician informed. Now we're moving on. There's a 72-week visit, again, a scheduled face-to-face visit with a nurse and clinical research coordinator. The participant brings in their study medications. The nursing focus is the same, answering the participants' questions, any flares since the last visit, how did management work out, and just reinforcing appropriate flare management using their personalized flare management medications. There's a blood draw for the 72-week visit. Again, can be done after the visit or separately as the patient prefers. An assessment of treatment side effects and adverse events, pill counts of the medications, study drug distribution if needed, again, to keep them equipped for 4 flares, and appropriately documenting the visit in the study database and the electronic health record. Now we're almost getting there. Remember, it's a 2-year follow-up. So the visit at week 84 is the penultimate, next to the last scheduled visit. It can be a face-to-face or virtual visit with the study nurse. It needs to be by video because there is a pill count involved. The nursing focus is the same as you've heard at previous visits. No blood draws needed for this one. There's an assessment of treatment side effects and adverse effects, pill counts of study medications, and again, enough medication for 4 flares. The appropriate documentation is always important, as well as the note to the primary care clinician. And at week 96, that's the last visit, the patient is actually done with the study at that point. It's a scheduled face-to-face visit with the nurse and clinical research coordinator. The patient brings in their study medications. The nursing focus is the same as at previous visits. There is a study blood draw at this last visit, an assessment of side effects, pill counts, but no new medications will be provided as the study is ended. It's important to thank the participant for being part of TRUST and to offer a summary of study results when they're available, which we'll send to all participants. And again, appropriate documentation of that visit and letting the primary care clinician know that the patient will be returning to them for ongoing management of their gout. Now, a couple of wrinkles. The nurse will be notified by the people who are making the regular calls to assess for flares if the patient reports a 3rd flare while in the study. In other words, it had 1, 2, and then 3 flares in the study. Either at the next study visit that's scheduled or an additional visit if the participant prefers, particularly if it's going to be a long time before the next visit. The nurse can discuss the option to initiate or escalate urate lowering therapy. Remember, some people can get in the study if they're already on a lower dose of allopurinol, 200 milligrams or less, so that option exists to increase their dose or start allopurinol if they've not been on it already. Now, initiating urate lowering therapy for a treat to avoid symptoms participant is an option, not a study requirement. A participant may choose just to continue managing their flares, particularly if they've been milder. If the participant chooses urate lowering therapy, allopurinol started at 100 milligrams daily, and for treat to avoid symptoms participants on up to 200 milligrams daily already at baseline, they can increase their dose by 100 milligrams. Now, prophylaxis is given for 3 months after either the initiation of the allopurinol or the change in dose. That will generally be colchicine. Subjects in the treat to avoid symptoms arm who choose to be on or to start or to escalate their doses can be given a maximum of 300 milligrams of allopurinol daily or 80 milligrams of febuxostat if they're hypersensitive to allopurinol. After initiating or escalating urate lowering therapy for a participant in the treat to avoid symptoms group, no urate monitoring is necessary. For participants who choose either urate lowering therapy or ongoing flare management, they return to the same visit schedule they've had all along. Now, for each additional flare after the third one, say the fourth or more, the nurse would be notified and can rediscuss urate lowering therapy initiation or dose escalation, again by another 100 milligrams. No urate monitoring is necessary. So basically, each time a flare happens after flare 3, there can be a discussion of switching to urate lowering therapy and ongoing flare management, of course. Now, unscheduled visits. Throughout the study, there may be times when a subject needs additional support or interventions from the nurse. The study nurse may schedule a telephone or video call with the subject as needed for reasons such as a difficult to manage flare, lost study drug. They've used all their study drugs and need more, for study drug questions, for lab abnormalities, for adverse drug events, or any other health concerns. We, again, would encourage nurses to set up a visit. And we hope they really are able to bond with our participants over the course of the study, which often happens in clinical trials. Now, at the visit, the study nurse would provide the appropriate intervention for the patient's concern, and they may consult with the study investigators at the site if they need help or advice in management, documenting the reason for the visit and detailing what was done in the unscheduled visit clinical research form. Interventions include providing patient education, distributing replacement medications, discuss lab results, schedule follow-up visit or call, joint aspiration or injection. Those would be things usually done by the investigators, recommending colchicine, naproxen, the study's preferred NSAID, or prednisone, or any other concerns the patient has. And again, the visit would be documented in the research database and the electronic health record, and the PCP would be notified. So again, that's an overview of what happens in the nursing interactions with participants who are randomized to the treat to avoid symptoms arm. Nurses will be managing about 55 of these participants at each site over time, and details of the medications, the visit are provided in the Treat to Avoid Symptoms nursing manual. Thanks for your attention, and thanks for your help with the TRUST trial.